While most of the native wall emergencies are due to regurgitations, prosthetic wall emergencies can be due to regurgitations or stenosis. Most common prosthetic wall emergency is due to prosthetic wall thrombosis in a mechanical prosthetic wall. This can cause acute stenosis, regurgitation, or both. Prosthetic wall thrombosis and thromboembolism are most likely during the first 3 months after the surgery for implantation of the wall. This is the period during which the wall gets endothelialized, after which risk of thrombosis is lesser. Thrombotic complications can be minimized to a large extent by meticulous anticoagulation management. Patients with prosthetic wall thrombosis may present with acute dyspnea due to pulmonary edema, cardiogenic shock, or neurological deficits due to embolic episodes. Though cases with very small thrombi may respond to anticoagulation optimization and intravenous thrombolysis, most will need surgery. Moreover, thrombolysis also carries the risk of massive thromboembolism, which could result in a major stroke, which may even end up fatally. In case of mechanical wall, the risk of thrombosis is present lifelong. Prosthetic wall thrombosis can be documented by echocardiography, fluoroscopy for wall movements, and computed tomography. CT may be useful in differentiating pannus from thrombus in a chronic case. Pannus is tissue ingrowth into the prosthetic wall and has higher density than thrombus. It can also elevate the transprosthetic wall gradient on Doppler echocardiography. Acute prosthetic wall related regurgitation can be due to suture failure or dehiscence following infective endocarditis. An unstable prosthetic wall can show an abnormal rocking movement on fluoroscopy. This produces paravalvular regurgitation, which can be progressive. Regurgitation in endocarditis of bioprosthetic wall can also be valvular. Infective endocarditis can be suspected if the person is febrile. Though difficult due to acoustic shadowing, vegetations may be seen on the prosthetic walls. Blood culture will identify the organism in prosthetic wall endocarditis and guide antibiotic therapy. Positron emission tomography (PET) is an important investigation in a case of suspected infective endocarditis when the echocardiogram is not contributory. PET scan will show increased uptake in the region of the wall in infective endocarditis. Regurgitation in prosthetic wall can also be due to a stuck wall. A thrombus between the prosthetic wall leaflet and the cage can cause a stuck wall. In a stuck wall, the leaflets are fixed in a partially open position, producing severe regurgitation. This can be identified by echocardiography and fluoroscopy if the leaflets are radio-opaque. Sometimes the wall leaflets are made of non-radio-opaque material and are not visible on fluoroscopy. Other rare causes of prosthetic wall regurgitation are strut fracture with leaflet escape and perforation of the prosthetic wall leaflets. These occur due to degradation of the material used for manufacturing the prosthetic wall. Fluoroscopy and CT scan may be useful in identifying these complications, which may not be evident on echocardiography. In case of bioprosthetic walls, both regurgitation and stenosis can be due to degeneration of the wall in the long run. Degeneration is more likely in younger individuals because of higher hemodynamic stress. That is why bioprosthetic walls are considered more often in older persons and mechanical walls in younger individuals. A rare case of bioprosthetic wall regurgitation due to wall perforation resulting from the use of an automated suture technique has also been reported. Here are a few important journal references. Thank you for watching this video. Please subscribe, like, share, and post your valuable comment below this video.